Consensus on Managing Open Ankle Fractures in the Frail Patient, Journal of Bone and Joint, published March 2024. Ankle fractures are common injuries, and the third most common fragility fracture. 40% of ankle fractures in the frail are open and represent a complex clinical scenario with morbidity and mortality rates similar to hip fracture patients. They have a higher risk of complications such as wound infections, Malunion, hospital-acquired infections, pressure sores, venothromboembolic events, and significant sarcopenia from prolonged bed rest. A modified Delphi method was used, and a group of experts with a vested interest in best practice were invited. In patients with frailty, the panel agreed to advocate a principle of judicious debridement rather than an oncological-style resection in the management of the soft tissue debridement. The use of negative pressure dressing over a closed wound is a valuable adjunct in high-risk wounds to support the skin closure and neutralize tension. The Allgauer-Donati suture technique has been shown to decrease wound tension and have the lowest impact on capillary blood flow. Unrestricted rehabilitation is facilitated by the use of surgical techniques that allow the patient to immediately fully weight bear. This minimizes the complications and morbidity of immobility in frail patients. There are many options available for fixation of an open ankle fracture, including joint-preserving and joint-sacrificing techniques. Irrespective of the surgeon's preference for fixation method, the goal to fully weight bear must remain the same. It has been demonstrated that in closed, unstable fractures in frail patients, tibiotalo-calcaneal nailing had a shorter length of stay and a lower complication rate compared to patients managed with ORIF or external fixation. In conclusion, 1. These patients have low bone density, and we should recommend falls and bone health assessment. 2. All open lower limb fragility fractures should be treated in a single stage within 24 hours of injury. 3. All patients with fragility fractures of the lower limb should be considered for mobilization on the day following surgery. 4. All patients with lower limb open fragility fractures should be considered for tissue sparing, with judicious debridement as a default. 5. All patients with open lower limb fragility fractures should be managed by a consultant plastic surgeon with primary closure wherever possible. And 6. The method of fixation must allow for immediate unrestricted weight bearing.